All right. Well, I think we already talked about it. This is not going to be a super long show. We've got just a couple stories we're going to run through this week, right?
Yeah, that's right. But I think, a lot of interesting dynamics going on. Just I'm not sure how they all fit together, but we should talk through them and just see. Part of the fun of it is just kind of exploring where it goes.
Yeah, these are 4 stories that I think tap into different stories over the last 12 or 13 shows we've touched on. Not a lot of I don't know. I mean, there were a couple of venture backing events, but I looked through them. I didn't see anything that felt like all that significant.
Yeah, VC is quiet.
VC, it's a quiet time in our industry. So anyway, let's go ahead and dig in. All right. The first story, I like this story because I think it's a clever story. This is about the California nonprofit hospitals turning to bankruptcy for leverage against the state. So a little bit of a continuation on where we left the last show, talking about health systems and sort of the challenges they have in getting mergers done, and particularly when AGs of the state are participating in blocking those mergers from happening.
Yeah, that's right. I mean, I think the reason I want to keep following this is that there's a lot of nonprofits that have significant debt and their operations have deteriorated, and they're going to have to figure out something. And that's going to involve maybe closing some facilities, changing things around, selling, merging, combining. And some AGs are stopping in certain states. I think it's about 10 or so states in this article have been stopping transactions from going forward. I think with the intent of protecting the population. They want to keep all the healthcare services being delivered. And as we talked about last week, that is laudable, but if you can't fund the operations, it's sort of a rock and a hard place. And then this came up this week out of California, where a health system, the Beverly Hospital, which is outside LA, they've been trying to sell the hospital for 10, I think it's about 10 years, 9 or 10 years. And it's been blocked several times with requirements like you can never shut down any of the operations. And so for an acquirer to walk into a fairly troubled health system and then agree that they'll never change anything is kind of a hard hill to climb.
Yeah. So it was a group out of North Carolina, American Healthcare Systems Foundation, that has been trying to purchase the Beverly Hospital. And after they filed for bankruptcy, they were able to get the AG's office to put together the acquisition. So,
yeah, I think the fact that it was in bankruptcy somehow changes the requirement for the Attorney General office to negotiate in a more constructive way, or at least get to the table and get a deal done.
Yeah, I mean, it's kind of like, a game of chicken, right? With these hospitals and with these AGs, where they're saying we need to merge, otherwise we're going to go out of business. And the AG is saying, I'm not sure I believe that, and you need to just keep providing care. And in this case, they went ahead and filed for bankruptcy, and that called the bluff. I mean, that said, okay, do you want care here? Because we're in bankruptcy now, right? You're gonna have to get somebody to come in and take this thing over. So this continues to just be a really interesting thing for us to track, because it's easy to talk about the common spirits, the Ascensions, the HCAs, these supermassive, multi-region health systems. But I don't think that that's the majority of hospitals around the country.
No, and they have issues, but they're well run.
That's right. Yeah. And they're almost like too big to fail. I mean, someone is going to come in and bring in some capital, private equity, or big government bailouts. Something will end up happening in those cases. It won't be pretty, but it will happen. But in these little onesie twosies, this is a 202 bed hospital, as you said, right outside of LA. Ain't nobody coming to their rescue, right? So,
well, and I think there's a question in my mind of, do we need as many 100-bed hospitals as we have? I'm not sure that I know. I certainly don't know in LA if this hospital is needed. But I think that it's we need to have some mechanism where we can get transactions and get companies reorganized.
Yeah, and I think the reality is that we, for those of us on the inside of healthcare innovation, we're thinking of and aware of all the different models that have been emerging. But, what's the truth about hospital at home? It's still so early. It's still being piloted. It's now in the hands of large organizations like Amedisys or, the Medically Home, group. They're partnered with big groups like Cardinal Health because they can handle a lot of the logistics and the delivery of things. But at the end of the day, like if you actually look at how many patients are on that platform,
not that many.
It's not real. It's not even real yet. So, we can talk about, do we need that many hospitals? But you got to have a bridge to something new. You got to have something new that's proven to work. And until then, even from the case of like, what do patients know to do, right? I mean, they know to go to the emergency room. They know to go to the hospital. That's what they know when it comes to, acute, emergency-based situations, and even chronic situations. I mean, the hospital is what they understand.
Yeah, I mean, I've been thinking about this a lot. I don't have an answer, but the fact that for-profit health systems are not interested in this property, and then nonprofits can't continue operations. They can't find a way to keep doing it. We need to find some way to treat the patients and make sure that there's enough coverage, but we don't need too much. Like, we don't need unlimited nonprofit health systems, but I don't know if the AG is qualified to make that determination. And yet there's not really a structure to say, but we have a free market-ish health system, but it's not totally a for-profit market. And we don't have a government-run system like they have in Europe. So we're kind of in the middle. And I think this is a good example of where the market was not functioning, and they utilized the bankruptcy law as sort of a tool to get something done. And we were talking about a Minnesota deal that got squashed last week. I think we're going to see this battle kind of happen a lot. There's a lot of health systems that are in trouble. There's a lot that are going to be fighting with various AGs if they're in a state that is concerned about the population, which should be every state, but is unequally balanced. And this seems like a tool that's going to be used more and more often because it worked in this case. Yeah. And so what they had to go to is like commercially reasonable terms.
Right.
Phrases like that. So they committed to keep the facility open as long as it was commercially feasible or something like that, which, is pretty standard language with a lot of outs in it.
Yeah. Let's see here. We're reading this from the Wall Street Journal. The Chapter 11 filing in April gave the hospital operator some leverage against the state's attorney general, who has the authority to mandate prospective buyers to maintain costly services such as emergency and charity care, and to accept patients covered by government-backed healthcare programs. So you can kind of get a sense of like where the fundamental issue is, right?
Yeah.
It's saying, okay, in order for you to have the opportunity to purchase this, you have to agree to X, Y, and Z. Basically, you need to be the kind of community partner we expect from you, irregardless of like the viability of doing those things.
That's right. You have to keep the ED open, emergency department open. You have to take California Medicaid. And I haven't looked into it, but
and charity care.
And charity care, right.
And you have to do stuff for free.
Yeah. And there's probably a reason that this system is struggling. Likely it's location or the patient referrals that happen into the ED are, probably not a lot of commercial or self-pay there. It's probably a lot of Medicaid or charity. And if you don't get reimbursed very much, you can't run the hospital.
Yeah. So this is just going to continue. From a healthcare venture perspective, I don't know about you in the deals you've been looking at, in your fund lately, but for us, it's been interesting to kind of come basically to the end of our first fund and, look at what we've been able to invest in that actually helps the health system. I think we've got one very clear company time study that is totally focused on, efficiency and delivering time studies and
helping understand what are our people doing now,
right.
and let's make them more efficient.
Yeah. So there's like a compliance, reason for that, but then there's also like an operational, excellence reason for doing it. But we've looked at so many companies that are talking about selling to health systems, and I think the more that we learn and we have partners and we have friends at these systems, and we go to things like the AHA summit every year, and just the more that we learn, the more we realize it's the foundation of this market is so soft right now that it's hard to get a good sense for where you can invest and reliably provide value to them, because there's so many fundamental issues. There's so many hair on fire issues, the payer mix issue, the 340B issues. Many much bigger issues that have to do with your interface with both the government as a payer as well as commercial payers. One of the big stories that's been, going on, it was just, talked about is denials, right? It was a big conversation at HFMA this year, and volume is up, but so are denials, right? And so how do we sort of navigate that? And, I'm not picking a side. I'm just saying, like, these are the continual issues that are in place. It's very hard to go to an organization when they've got so many fundamental issues and talk about, I'm going to improve stuff for this segment of your population, or I'm going to help lower your costs here, or whatever. Even if it's really valuable, I just am finding it to be very, very difficult. Furthermore, it's also very hard when the solution is not very robust and mature, and it's hard to get it to be robust without getting uptake. So it feels like it was easier in the past, but as things get more difficult for health systems, it's just getting fundamentally harder to effectively sell innovations into health systems. At least that's my perception.
Yeah, I think that it's always been true, and I think it continues to be true, that kind of the value network or how hospitals or payers sort of deliver value for their customers is fairly complicated. There's lots of parts to it. And so for a seed stage company, for an early stage startup that's just getting started, typically they want to take one kind of point solution and really understand the customer pain points, try to make that experience 10, 15, 20 times better, so that it's hard to get people to change their day-to-day behavior. I'm not going to bother if it's just like an incremental tiny change. Mm-hmm. So giving like a quantum significant, it really changes my work life. Now I can get adoption.
Right.
The issue is that in health systems, it's very complex. There's lots of different pieces and parts that all work together. So it's hard to isolate. We're going to help this piece be 20 times better, because it's kind of dragged down by all the other pieces. And so I have a new fund. I've made one investment. I'm looking at several more, but I'm looking to do 10. We're really trying to find where can we isolate one piece of the chain and sort of own that and control that and give great value. And you have to be really clear about what are you solving, understanding many of the things. It's a great idea, but it's so intertwined with other stuff that I can't really prove that it's going to work. And then if the health system doesn't do their part, my company doesn't get the benefit.
Mm-hmm.
So some things that could be great, they just it's like too hard.
Yeah. It's and also like a lot of the larger systems will say, go test this out with a smaller system or like a single hospital. Well, single hospitals are fighting to stay alive.
They will say that, and that's not a viable path.
Yeah.
The small systems can't do anything.
It felt like it used to be more viable, though, right? It felt like smaller systems used to have more bandwidth, more ability to actually, work with you, collaborate with you as an early stage company. But they're just under so much stress now that channel is it's hard to break through. It's hard to break through. Okay. Related to these economic challenges, you found this story. I can't believe I didn't see this. The downgrade of the nation's credit rating from Fitch. Yeah,
so there's 3 credit rating agencies that sort of rate all the debt around. Fitch is one of the 3 big agencies.
Is Moody's one of the?
Yeah. Moody's and S&P.
S&P, okay.
So they downgraded U.S. government debt from AAA, which is the top that it's been since the U.S. was founded, to AA plus, which is the next level down. But that really shocked me. It shocked the market. The market was down. And I think it's just worth talking about. Like, this is, I think, not going to matter in that people are still going to buy government debt. But it is symbolic and kind of a sign of us headed in the wrong direction. So I think it's a pretty big warning shot, but I also don't have a lot of confidence that the politicians are going to heed the warning.
Well, so this is a DealBook newsletter that's writing about it, and the subtitle
part of the Times. I think that's a segment from the Times.
Mm-hmm.
New York Times.
Yeah. Well, DealBook is Andrew Ross Sorkin's thing.
Okay.
Inside the Times. So the subtitle here highlights that the downgrade admonished Washington for persistent political fighting over federal spending, but the move drew sharp criticism. So, I mean, I think that's something to just spend a second talking about, which is the culture war, right?
Yeah.
It is getting to a point where it is concerning people, right? And I think what's interesting about it is,
and I intentionally, so I read the Times and the Wall Street Journal every day, so that I can understand the 2 sides of America.
Yeah.
And I intentionally went to the Times to get the story for the podcast. I mean, both papers covered it, of course.
Sure.
Because I think the Times is more friendly to Biden. And so we should talk about the culture war. And I think even the Times was covering this because it's a bit, it's a big move.
Yeah. And I mean, it's a big move, but let's just take it on the face and let's say Fitch's downgrade was in fact about the political fighting over federal spending, right? Like it was highlighting that as a risk.
And just to be clear, Fitch warned that it would downgrade the U.S. when the debt ceiling fight was going on. Mm-hmm. That warning came out, and I think that was a catalyst that helped us actually get it done before the deadline. And so they've been in this kind of activist credit rating agency sort of role, which whether that's a good role for them or not, they've sort of been the one of the 3 that's been doing that.
Well, I mean, I think that they are representing at least some segment of the business world that feels that the culture war is not productive for a stable business environment, for a stable economy. When I was at the Axios BFD event in San Francisco, TPG's CEO was there, and he was asked about he was asked about the debt ceiling, and he said he thought it would get done, but more so than any other year, he was concerned about it getting done, right? And I think that's probably represented in this downgrade, right? Which is to say, okay, like, you got it done. We knew you were going to get it done, but you're scaring everybody. You're scaring everybody into thinking you might not get it done. And we know that there is a political theater. We know that there's a negotiation model, and that's all sort of understood. But the vitriol that's happening around this feels very, very much like the fabric is fraying, and I think that this is a good. I think it's good because we need more organizations, institutions to acknowledge that this is happening and to say, listen, yes, the economy, GDP growth last quarter, pretty good given everything that's going on in the world. Is the U.S., really in any serious threat of being unseated as a reserve currency? Not in the near future. I mean, everyone understands that. We understand that this is a game of relativity, right? And if you look around the world, I think the UK bank just had to bump up the interest rate again, and they have a much harder time dealing with inflation than we do. Europe's got all sorts of problems.
We're the
France
least bad. We're the least bad place.
That's
we're
right.
Not good, but we're the least bad.
Yeah, and certainly in the Western world right now. I mean, the Western world's kind of really, really weak right now. So no, I mean, I don't believe that the U.S. is in any risk of not being the world's reserve currency in the near future, right? So let's just go ahead and say that, relative to all the other options that we have in the world. However, in a battle against itself, right? In a cohort against its former self, it's not stacking up very well, right? Against itself.
Right.
From 10 years ago, 20 years ago, right? It's
I mean, I think it's sort of Fitch's job to rate the U.S. debt on behalf of the debt holders. And I think what they're saying is, whichever side you happen to sit on, the two sides shooting at each other is not good for the debt holders. And what's needed is the politicians to be adults and actually create a workable plan that no one is that happy with, but that everyone can live with. And I think this is a warning shot that for our 30-year debt, it's not out of the question that there's worries out there.
Yeah.
And I don't mean that we couldn't build our economy and create taxes and pay debt. What I mean is that the Republicans and the Democrats, both sides, it's hard to be 100% sure that they will be adults. Either side could get so petty and focused on winning the next political poll, whatever, that they do something that is strategically good to win that next victory that doesn't really matter, but really bad long-term for the safety of the overall economy and the debt. And I think that was the message. And at least that's what I took from it. And that's a pretty sobering message. And I can't say I disagree with it. I mean, it's probably right.
Yeah. And there's two things that are relevant to health further besides the fact that, we're talking about the United States.
We live in America.
Right.
Yeah.
One sort of obvious is the percentage of GDP that healthcare represents, and specifically the percentage of the deficit that Medicare represents, and that number is growing with no sort of real end in sight other than if you really project out past the baby boomers being alive, right? Then you have sort of a decline as you head into Gen X. We're just a smaller generation, but that's a ways out.
Yeah. And no one is even on either side willing to have a discussion about the entitlement. So Medicare, Medicaid, Social Security, but no one will discuss it. And so we know this is out there and going to be really expensive, and a huge percentage of our economy is going to be used in that or in servicing the debt of what we've already paid for. and no person will speak the words. And so that's concerning.
Well, what I think is so disheartening is that it is such a massive opportunity for innovation to play a role, right? You've got this chart that is only going in one direction, right?
Mm-hmm.
And you've got this capital market that is chomping at the bit to find a way to extract value out of healthcare and lowering that Medicare cost. I mean, there's so much money to be made there. There is so much money to be made if we could figure out how to actually turn that around. And we've got this ARPA-H initiative that's part of this administration, and it's look, I applaud the government pulling out several billions of dollars, which in the context of a multi-trillion-dollar is
sounds like a lot, but it's not a lot.
It's not a lot of money, and really saying in a very short period of time we're going to allocate that to innovative companies that are going to really go after some of these big hairy healthcare problems. Mm-hmm. But man, it feels like there's more that we could be doing there, right? It seems like we could look at the direction, look at what this is going to cost in the future, grab some of that and really, really work with the private market and really work with the commercial payers to try to tackle this thing in a serious way. I mean, I think about the way that we're going about it right now, and it's so hard to get anything done in that space. And just in the context of how much Medicare contributes to the deficit, I mean, there is a national imperative for us to try to turn that around. And so to your point about like, we're not even willing to have a conversation, I mean, it seems like we should be willing to have a conversation at least about investing in innovation, which has clearly been how America has led the world's economy. Like we are the best innovators. Like, couldn't we leverage that proven track record of capital into innovators to, really lower the cost of just about everything, to lower the cost of Medicare? I mean, it seems like it's something we ought to be able to get done with the right kind of focus.
Yes, we know people to call, and there's a lot of people with really creative ideas. What is not allowed right now is any kind of long-term solution that is not going to fix something. We were talking about it in the last segment, not going to fix something that is like immediate value this quarter. Like some of these things are, like I'm 10 pounds overweight. I should lose a little weight. I should work out more. That's going to affect my cost of care in 20 years. And I don't have the proper incentives. I have incentives to save for retirement. I don't really have incentives to save for healthcare. Mm-hmm. It's not designed the same way. It's structured for the state of the world in 1965 when most people died by the time they were 70. And we don't have that anymore. And instead of just saying, as adults would, okay, we know people are going to live till 85, 90. Let's try to rethink this, not for the people that are in Medicare now, but I'll be 70 in 2040. And I don't know if Medicare will be around or not.
Yeah.
And I'll be 70 years old. I'm still going to be, hopefully on this podcast, I'll still be working, but things I'm doing today hopefully will make me more healthy then. And there isn't, and I was talking to my son yesterday, who's 18. He wants to start saving for his retirement. He had learned about that in high school. He now understands compounding, and he's telling me I got to start, which is great, right?
It's amazing.
But healthcare compounds too. And we don't teach that. We don't talk about it. We just kind of ignore it. And then we are surprised when people get to 55, 60, 65, and they have a lot of health care because they've been unhealthy for a long time. So these problems are, I mean, I went to Oppenheimer last week. It feels like the United States was like really pulling in the best and brightest people. We didn't understand everything. Lots of stuff was not safe, poorly done, and questionable whether it was needed or not. But we wanted to lead and find a solution and just put in anyone in the middle of nowhere to try to figure this out. We don't do that stuff anymore. We're just planning for the next election. And that's not going to work for our kids.
No, and think about in your own life. I mean, to the listener, think in your own life, would that work? I mean, of course it wouldn't work.
Right.
Of course it wouldn't work. Like you have to, you have to have a balance of things you do for the short term, things you do for the midterm, and things you do for the long term. And that's, that balance is how you don't go crazy today. You're also a step ahead of what's coming up next week, but also in the years to come, you're being kind to your future self.
Yes.
Because if you're old enough, like you start to get the sense of future self is a real self. You know, like I am future self of an old Marcus.
Wishes that 23-year-old Vic, maybe slept a little more.
Right. Exactly. Exactly. So I think there's just something around. There's just something around that, and you could say that this downgrade from Fitch, you could isolate it to the bad behavior in DC politically, but I think there's also, and this could be a symptom of the bad behavior. In fact, it could be argued that it absolutely is, but there's also just this this unwillingness to actually try to change things for real, right? Everything is more oriented around maintaining and kicking things down the road than actually going after something for real. And I think that there's something about the deficit and the charts only going sort of one way. And then, when you layer on really, really bad behavior, it should indicate at some point, we don't know when, but at some point, America is setting itself up to run into a wall, right? I mean, that's kind of what we're doing. If we believe the things that we tell ourselves in our own lives or the things that we tell our children, right? We don't know when. No one can sort of point to the time on the calendar when it's going to hit. But the compound effect of this behavior, this bad behavior, this kicking things down the road constantly, with the only solution being manipulating currency.
Yeah.
Right.
Print more money and manipulate the interest rate to make it be reasonably okay for us. It hurts the rest of the world.
Yeah. Like if you don't believe that would work for you personally, and you would certainly not advocate that for your child, at some point you have to realize, like, in a world of you versus you, or you caring for future you're not doing a very good job. Right.
Yeah.
Forget about the competition. Like just you versus you caring for future you're not doing a very good job.
I want to come back to where you started, because I think you were really close to something that I've been trying to think through, which is, I don't think the political parties on either side, okay, so Republicans and Democrats.
I mean, you haven't heard me call out a particular party.
I
just said the culture wars.
Any of them actually want to solve the problems that we face. And so we have two parties that are sort of rallying their talking points to raise money, to get out the vote, to sort of drive them back into office. But I don't think they're actually trying to get to a solution. So, I mean, I'll step into this and get a bunch of hate mail, but I mean, I think gun control is the easiest one. Like, there are multiple things. I mean, we live in Tennessee. Like, I have a ton of friends that hunt all the time.
Sure, of course.
That love their guns, and no one's trying to take their hunting away, right? But an AR-15 with no background checks, like the general population of either political persuasion, there's a certain set of things that you could agree on if you all sat in the same room. And yet it would stop getting the vote out. It would stop raising money. It would for both sides. I mean, and so both sides want the topic to sort of be perpetuated for their own selfish reasons, and so it is. And then we never get to any solution. Their job is supposed to be to create laws that are reasonably good for the society, and I don't think they're doing that job. So this will be, I think we will look back and say this was a sign on the way towards the cliff. Hopefully we will pull back before we go off the cliff.
Well, I would say the responses to the downgrade, which are predictable and understandable, Treasury Secretary Janet Yellen called the downgrade arbitrary, noting that Fitch has shown U.S. governance deteriorating as far back as 2018, but hadn't moved until now. The American economy is fundamentally strong, she added. So,
true, but not the point.
Correct.
Right.
True, but not the point. And also, how many people would say that we are in the same place from, political bad behavior?
That's 2018.
It's not even the same world.
Right.
It's literally not even the same world. So, yeah. And then you've got Paul Krugman and Larry Summers also calling, the move bizarre, saying, I can't imagine any serious credit analyst is going to give this weight. So, those responses, which I think are more pointing to the fact that we may be bad, but we're the best that you got, right? To me, that's really what's being said here. It doesn't deal with us on our own scale, us versus us.
It's avoiding the point.
Yeah, it's avoiding the point.
I think that there is no other AAA rated country-backed debt that has debt to GDP over 100. Right? So like Singapore, Norway, Finland, they are rated really strong, and they're like 25%. And now we have a very dynamic, very strong economy, and it maybe can outrun 120% debt to GDP, because GDP could, in theory, grow. But I think the point Fitch is trying to make is that we have to actually try.
We have to try. And we're not trying. Let's move to the next story. This was a big headline this week. CVS cut 5,000 jobs. I think you did the math. They have 300,000 employees. Mm-hmm. So, it's a little north of 1%, but I mean, when we compare it to the average percentage haircut that the tech companies were doing in the first quarter, which was 7%, it's really not much at all. We have to put this in the context of two major acquisitions that they did in Oak Street Health and Signify Health, which I think combined were about $20 billion between the two. And so, it's weird, right? I mean, all layoffs are sad, but I think in the context of all of those things, this feels really just like they're just tightening up the ship and working on integrating these two new, really important, pretty expensive assets that they purchased. And, it also sounded like these jobs were not consumer facing, out in the street. Yeah. They were like back office corporate jobs. Yeah, it doesn't mean it's any sad. It's any less sad.
Yeah. But. I mean, for those 5,000 people, it's sad. I'm worried about the job market. I mean, other people think it is hot. I think it's going to be a challenge in the next 6 months. But CVS, I think, has been sort of pivoting over the last 8 years from, your convenience store with a pharmacy to really a healthcare company. And these acquisitions of Oak Street and Signify, we've talked about them before. Those were big investments in new capabilities. And I see this as sort of a continuation of that. They're sort of reorienting themselves to be a healthcare company that's delivering care, and they also have an on-site location for urgent care, and you can get your meds there. And then They have convenient goods you might pick up. So I think they're shifting. I don't exactly know where it is, but in management or in the supply chain or in retail or maybe in their retail buyers, I don't think it cut a lot of people that were facing customers. They said it wasn't. And then they came out with earnings the next day, beat earnings, but their acquisitions are being incorporated. Oh yeah, we have a report on it. So stronger demand, increase in revenue. They beat earnings, but they were cautious about forward guidance.
Mm-hmm.
And they were discussing all the expenses related to these acquisitions being integrated. So I think it was partially sort of getting the layoff out in front of that to have like all the news at the same time be out.
And sorry about all the coughing, guys. I'm just fighting a little cold here. But
I had it in episode 2 or 3. So
yeah, I know. It's about time for me. So you said something interesting that made me think. You said over the last 5 to 8 years. And, I can remember. So we've been doing this full time for 9+ years now.
Yeah.
And I can remember it since we started working together when CVS stopped selling cigarettes.
Yeah. So that was the first public thing they did in recognition of this is not healthy. This is not,
right. So that's been in the last 10 years. So I think I wanted to point that out just to say we talk a lot about United Health Group as, for whatever you want to think about them, just coming back from the conversation we just had, that's an organization that is going for it. Okay. You know what I mean? They're not trying to do little incremental things here and there. Like they are going for it. They are trying to build the healthcare company of the future for the United States. And you have to at least applaud the ambition and the moves that they have consistently made, really in their case, for multiple decades. The reason why I'm bringing them up is I think when you look at CVS, the market talks about how they constantly disappoint, blah, blah, blah. I think they deserve a lot of credit for what they've done over the course of 10 years. You go from a drugstore that was really very convenience-y store. You were selling cigarettes 10 years ago to let's look at the moves they've done. They've rebranded to CVS Health. They
bought Caremark. Caremark was even before that.
Yeah.
And that's if you don't have like Rite Aid is going to die.
Yeah, for sure.
And it's because they don't have the PBM.
PBM, yeah.
And so CVS has Caremark. I think they changed their name just to CVS now. But and then United has a PBM. Cigna has a PBM. I don't know if Walgreens does, but without a PBM, it's really hard to be a pharmacy now because they just sort of like transfer pricing you out.
Right. But
anyway, yes, they've been pivoting and they're having to survive in this public market quarter to quarter, but I think they have a longer view on things.
Yeah, well, hold on. Let's keep stacking the things. Yeah. So stop selling cigarettes, change your name to CVS Health. As you said, bought Caremark. That feels pre 10 years.
Yeah,
right?
yeah. Caremark was in 2010.
Yeah,
something
like that. That was a while back. Yeah. Merged with Aetna.
Yeah.
Massive move, right? Huge. So that put them in the Payvider world, right? Bought Oak Street, bought Signify, really, pushed for CVS is Minute Clinic, right? That's their brand.
Yeah, they were one of the first to be urgent care Minute Clinic.
Yeah. And then double down on that with the Health Hub idea, which I've been to a couple of Health Hubs now. They have one in DC, and they're
pretty one. Yeah.
They're pretty impressive. I mean, what they're clearly you see the aspirations of what they are trying to do, how they are transforming their space. Now having bought Oak Street and having Signify, I mean, that's a lot of moves in a 10-year, and if we add Caremark, let's just we'll call it 15-year. That's a lot of moves in a 15-year window to position yourself to be a healthcare company of the future. To me, it's really, really impressive. To me, it's impressive.
Yeah, that's right. They have a long-term strategy and they have like quarter-to-quarter execution. It's hard to pair those both together in a public environment where you're under so much scrutiny.
Yeah, and look, they're gonna suffer from the same issues that all managed care organizations do in terms of, they get tailwinds and they get headwinds. You know what I mean? So they had tailwinds during COVID. All the payers stacked all this cash during that time.
They did these acquisitions.
Right, exactly. They spent $20 billion and bought two, future-proofing companies.
Yeah. Now for our health system friends, reimbursements coming back.
Yes.
Utilization's coming back.
Yes.
Patients are more sick. So it's going to push claims through CVS and United. But that's a give and take. That's sort of
that's pendulum swinging.
Right.
That's pendulum swinging. That's right.
Yeah. We don't have a story, but Cigna came out with earnings this week as well. And they were good. They beat moderately. They're the same. They have a PBM. They're seeing costs rise a little bit, but they can withstand it.
Mm-hmm.
They're behind, I'd say. They're trying to more follow the UHG playbook, but they're
with Evernorth
behind. With Evernorth, yeah, exactly. Yeah. So,
well, they just don't have the front door footprint, right?
They don't have the front door compared to CVS, and they're just 10 years behind Optum.
Yeah. But
they're working on it.
But they're building the same platform out.
Yeah.
That's right. Okay. And then final story.
This.
Oh yeah. Thanks for the reminder. Vic had to remind me that it's time to go to a break before we hit our last story. So we'll take a break and send it to Doug, and then we'll be right back.
Thanks, guys, for the opportunity to talk about our pre-seed fund, Jumpstart Foundry. My name is Doug Edwards, CEO of Jumpstart Health Investors, the parent company of Jumpstart Foundry. We're so excited to be able to talk about early stage venture investing, certainly the need for us to change the crazy world of healthcare in the United States. We are spending 20% of our GDP, north of $4 trillion a year on healthcare with suboptimal outcomes. Jumpstart Foundry exists to help us find and identify and invest in innovative companies that are going to make a difference in healthcare in our country. Every year, Jumpstart Foundry invests a fund, raises a fund, and deploys that across 30, 40, 50 assets every year, allowing ease of access for our limited partners to invest to help us make something better in healthcare. Some of the benefits of Jumpstart Foundry is there's no management fees. We deploy all the capital that's raised every year in the fund. We find the best and brightest, typically around single-digit percentage of companies that apply for funding from Jumpstart, and we invest in the most incredible, robust, innovative solutions and founders in the United States. Over the last 9 years, Jumpstart Foundry has invested in nearly 200 early-stage, pre-seed stage companies in the country. Through those most innovative solutions that Jumpstart Foundry invests in, we also provide great returns and a great experience for our limited partners. We partner with AngelList to administer the fund, making that ease of access not only with low minimums, but the ease of investing in venture much better. We all know that healthcare is broken. Everyone deserves better. Come alongside us with Jumpstart Foundry, invest in making the future of healthcare better, and make something better in healthcare. Thank you, guys. Now back to the show.
All right, we're back. Final story. We're bringing back the Ozempic because I don't know. Every week, it turns out that this drug can solve another 3 things, not one thing.
It's a magic thing.
This makes sense that Ozempic would not just help with weight loss, but it would also help with addiction. You could say that, weight gain could be derived from some addiction to eating. Addictions typically are sort of dopamine issues, people just not having good dopamine regulation and needing dopamine all the time.
I think you get a dopamine hit when you are hungry and eat food. So the GLP-1 pathway, it makes sense that it is tied to making decisions and sort of driving behaviors. Mm-hmm. And if you change that, you feel less hungry, but you also have other things you're addicted to. And so it's a video, so we can't really play it, but it's a Wall Street Journal study about or aggregation of lots of medical research that's early. So it's not ready for human consumption.
But there's a bunch of clinical trials going on.
Yes.
That's the key.
For behavioral health and addiction.
And I watched the video, and it's pretty easy to follow along and make the connection. So if you wanted to see the video, Wall Street Journal, just look up, here's the headline: Ozempic's other unexpected side effect is all in your head. We'll obviously put the link in the show notes. But yeah, I mean, look, it really does make sense that so many of the issues that people struggle with from a behavior perspective are tied into dopamine and dopamine regulation and, just being sort of addicted to dopa hits.
Yeah, I mean, I was at a panel thing yesterday. We were talking about behavioral health in virtual care, and then we were saying it. Behavioral health. If you're depressed, if you're anxious, if you're dealing with all of these behavioral health things, sometimes it sort of presents in you being really lethargic and not exercising, or you might eat much more ice cream or more pot. Like, people have different ways that they kind of self-medicate.
Mm-hmm.
It's not always self-medicating with an opioid.
That's right.
You might take a drink. You might eat chips. And it's not necessarily you're hungry. You just are like trying to distract yourself. And so behavioral issues, I think, are intertwined with health and diet and eating and everything. So I think it does. It fits. It makes sense.
Yeah, and we're learning more now about those behavioral issues having real brain chemistry drivers, and that it's not just us. Kind of all animals. They do the test with rats, and it's like, there it is. If you address this GLP-1 issue, you can manage the dopamine, the response to the dopamine, and it just kind of makes you more content with things the way they are. It just sort of, brings down your response to the dopa hit.
Yeah. So, I mean, if we can get it where it is a intervention that helps me lose weight, say, it helps me get onto much better habits, and I lose 30, 40, 50 pounds. Now I can go on a walk more easily. Now I can eat, and then I can titrate off it and like ramp off it. And I have much better habits, and I don't have that cycle of I'm eating a lot, then I feel kind of lazy and sick, and then I'm depressed about that, and I eat more, and you just kind of never end.
And I drink. I mean, the thing about this story is it's talking about how it makes people not want to drink, right? Which is obviously also connected to obesity, but also connected to some really other very bad things. I mean, I think overeating is one thing, but over drinking is an organ killer, right?
Yes. So this is it's a really promising set of treatments. Ozempic is the most well known, but there's going to be a pill form. There's going to be a lot of medications that come out in the next couple of years, and I think it's going to really be impactful to our health system.
Mm-hmm.
But it's expensive.
Yeah, it's expensive. And that takes us to our final little story here, which is around employers cutting off access to weight loss drugs for workers. So they're talking about Wegovy, which is in the same sort of family as Ozempic, and how employers are just saying it's too much money. I didn't know how much it actually costs, but it's cited here in the Wall Street Journal that this class can cost as much as $1,350 a month for a patient. Now, I will admit, when I saw that amount, I didn't think it was that expensive. Now I understand when you think about the number of people who suffer from obesity, that's going to be a big number at scale. But when I think about the downstream health benefits and the cost savings of having people who
$20,000 a year, right? So if you don't need a new hip, we're done.
That's kind of my point. That's my point.
Never mind the cardiac care, the COPD,
right?
And I think the issue is the CFO. I can imagine a CFO saying, "Listen, CVS has 300,000 employees. We have 300,000 employees.
X percentage are obese.
25% at least.
Yeah,
more than that probably, but 25%. So 75,000 want this, and I got to pay $1,300 a month. So that's $100,000 a month. No, it's $1 million a month.
$1 million a month.
$1 million a month.
Yeah.
how many of these people will still be here
Right.
when I get
Right.
the year, 2, 3 years from now health savings?
Right.
Well, my churn is X,
Right.
and it's just a math equation. I think
Yeah.
they're saying, I'm not sure the benefits will accrue to me, but this goes back to you're saying we should sick entrepreneurs on working on it. It's a time and incentive problem. There's no question that if someone is obese and they get on Ozempic and they lose 40 pounds and they're much healthier, and then if they can get off it and sort of not pay that the rest of their life, which I think is not that well studied, but hopefully they're not on this drug forever, they'd be much healthier, more productive, and they'd be less expensive across a 10-year period of time. So now we're just talking about like, well, who's going to get that benefit? And part of the issue I have with employer-based insurance is, one, it gets underwritten year by year. And so there's really no benefit for anyone to think longer than a year. And two, you can't take it with you. So like, if I could have my own personal insurance, I might have 5 jobs in 10 years, but I can take it with me like life insurance, then I'd have much better incentive to reduce it. But we don't have that system. So it's a misalignment of things. And so for now, employers are declining. And I think this is going to be a trend. There's going to be a lot of drugs that come to market that are very effective and somewhat expensive if you have a 1-year time horizon.
Yeah.
But really effective in a 20-year time horizon. And we don't have payment structures for that.
Well, this is very much a continuing story, because we didn't really go into it, but at the end of that video, they even show off some of the early indicators that that Ozempic could be beneficial for holding off Parkinson's and Alzheimer's, which they're sort of connecting everything back to this GLP-1. And how it has all of these benefits. So this is going to continue to be a story. I mean, as we continue to find out what this drug actually can do, we'll eventually figure out what the side effects are. But gosh, it really is tackling so many big problems that we have. And, I, for one, am very excited to find something that can work, can be affordable, and can really start to make a dent in some of these American issues that we have.
I think
for our population.
It's going to be incredible. And then GLP-1 is one of the pathway signals.
Yeah.
But I was trying to study about it last week, and there's a lot of science, but there's lots of pathways related to diet and the feeling of being hungry, and then how you process food. And with CRISPR and AI and all the protein folding stuff Google's doing, I think there's going to be a lot of new treatments that come out, which is wonderful. And not many of them are going to have a 1-year impact. They're going to have a longer term benefit that we need to figure out.
Yeah, and we also need to figure out how many of these things can actually get to market. I mean, I would love to see the backstory on how this particular drug got to market. There was a gathering, and I'd like to actually go into it on the next episode, but there's an article in Stat that talks about some of the challenges that the biotech industry is currently facing, just because there's so many assets that are living in universities across the country right now. They can't get any capital. The regulatory pathway is pretty difficult to move through. And it just seems like we're on the precipice of so many incredible breakthroughs from a science and a technology perspective. Pharmacological, cell-based, autologous, it just so many things that we could be doing, but they've all got some type of barrier to advancing to a place where we can actually use them. And what is going to be the answer there? It's not clear that in a post ZERP world, where the interest rate ain't going back to zero anytime soon, that the capital markets are going to be accepting of kind of the non-productive, economic model that biotech provided, right? And so I think we have to sort of rehash that entirely.
Yeah, and I think that's an entire show. But I think Ozempic, I believe, came out as a diabetes drug, and now it is, I think, being done mostly off-label, but it's being prescribed for weight loss.
Mm-hmm.
And so I think that's one pathway that you pick a market, but then it broadens over time.
Mm-hmm.
The other thing that will make this a longer conversation is I think there's a lot of longevity interest in individuals paying for biotech to create things that can be an interesting pathway. Because there's a lot of, it's a K-shaped economy, right? There's a lot of people that are suffering, but there's also a lot of people that have made a ton of money in the zero interest rate environment that now want to live forever. And so like getting that all aligned where they do work for their own selfish live forever interest, but then it populates down to the whole group of people over time, I think is something to think through.
Yeah. I think the FDA is important there because I think there's a lot of, forget the longevity world, there's a lot of athletes today who would like to have access to stem cells, for example, and that's illegal. You can't do that today. You can do PRP, but there's really strong limitations on what you can do to cellular matter and actually put it into the human body today. So as long as we've got those huge blockers in place, I think even the longevity folks are kind of limited in the impact they can have for the broader society.
Okay, well, I want to learn more about that. So not embryonic stem cells, but just any stem cells?
You can do PRP, which is taking your own blood, put it in a centrifuge, and then, it kind of gets enriched through that process, and then you can put it back in. And I think there's like 3 or 4 areas where, generally speaking, it's been proven to help with the symptoms that you may experience.
I've seen it for orthopedics, hair growth, stuff like that.
Yeah, exactly. But exogenous cells are not allowed. You can't, there was, I think there was like some like, umbilical cord stuff that they were, messing around with in the past. But I think all of that stuff's outlawed at this point. And I don't think you can do any of it. I think it's all illegal. So, that's something we should look into that along with the biotech story for next week.
Yeah.
I do want to dig into that. Obviously, that's an innovation space. That's capital markets. There's a ton of assets that are out there. It's a big percentage of what the tech transfer world is trying to do. Vanderbilt is very well positioned to do things there, but you got to have the capital in the private markets to actually advance that stuff.
Yeah, and the tech transfer commercialization is hard. I've been trying to work on that for a long time. Yeah, it's hard.
It's hard anyway. All right, man. Look, this is a better show than you thought it was going to be.
Yeah. It's always good when we get live and just talk through things.
Yeah. And we're live back in the office next week. Maybe we'll try to find a guest.
Yeah. Let's. We'll talk about it. I have some ideas.
Okay, good. All right. Well, thanks for listening. We'll see you next week.